From Microbe TV, this is TWiP, This Week in Parasitism, episode 129, recorded on March 15th, 2017. This episode is brought to you by Blue Apron. Blue Apron is the #1 fresh ingredient and recipe delivery service in the country. See what's on the menu this week and get your first 3 meals free with your first purchase with free shipping by going to blueapron.com/TWiP. Hi, everybody. I'm Vincent Racaniello, and joining me today in New York City on the Ides of March, Dickson Despommier.
Beware, Vincent. Be very aware.
And from a remote location, Daniel Griffin.
Hello, everybody. I like that, from a remote location. You're supposed to say, and not to be disclosed or something, more mysterious. But I'm excited to be here.
You're our doctor at large.
We had a big snow yesterday, and
oh yeah, how did you do out in Long Island?
Very cold. You got a lot of snow out there.
There was quite a bit, but what happened, which made it difficult, was first the snow came down, and then it rained afterwards, just making it all thick and heavy. And as I was saying, but it was okay because I had a bow tie for the occasion, which has this marble nematode parasite from Smilla's Sense of Snow. So it was all good here.
That's nice. Do you have a bow tie for every day of the year?
I am working.
Tomorrow's National Secretary Day. I don't know what you're going to do about that, but
it's got to be a parasite that affects secretaries. So
it's the secretary bird parasite.
Let's go on to our case for TWiP 128. Yeah. Daniel, bring us up to speed.
Yes, for everybody tuning back in and those tuning in initially, I, as I said, was not sure anyone would get this, but this was a case from a colleague of mine down in Australia. And the case involved an 80-year-old retired teacher from Atherton, Northeast Australia, who had presented to the clinic with generalized weakness. There was a concern for chronic Lyme, Q fever. She'd been seen by a neurologist previously before coming to my infectious disease colleague. And there was concern for motor neuron disease. The clinical story was that there had been 18 months of illness. It was an insidious onset, initially with limb, arm and leg weakness, no issue with speaking, swallowing, or breathing, no weight loss, no fevers, no sweats, no chills, just, as mentioned, this progressive generalized weakness of the limbs. There was a history that she had of osteoarthritis, joint replacements, myocarditis, vertigo. She reports an allergy to penicillin and doxycycline. She has a family history significant for her father with rheumatoid arthritis, a brother with colon cancer, and she's on a number of medications, which we pointed out one of them was a statin. She does extensive travel, but when not traveling, she's a volunteer carer in Australia, taking care of abandoned wildlife. She's been doing this over the last 3 years, and she lives with her husband. And we went into a little bit about the different animals that she's involved with. So she's handling and feeding marsupials. She hand feeds puggles, which I think are juvenile spiny anteaters. And she has a pet cockatoo. She has no history of polio, HIV negative, and her exam shows a diffuse non-tender muscles, but no rash. She has normal upper and lower limb tone, but the strength is symmetrically reduced, and it's reduced more proximally than distally. Her reflexes are good at the knees. She has normal sensation, all modalities. She has a normal cranial nerve exam, and her test results demonstrate eosinophilia. She has elevated muscle enzymes. An EMG shows myopathic changes. She has a nerve conduction study, which is normal. One of the first things that is done is the statin is stopped, but this does not change things. And I threw out to people that this is a rare parasite.
All right. We had a good number of guesses here. Everyone has rebounded from their lethargy of a few episodes ago. Peter writes, "Greetings, TWiP team. Patient suffering from a generalized muscle weakness that As this is TWiP, I will assume is the result of a parasitic infection. Myopathy refers to a muscle fiber disorder. This myopathy presents as pure motor syndromes without any disturbance of sensory or autonomic function. Deep tendon reflexes are preserved. High muscle enzyme are the result of damaged muscle tissue releasing enzymes into the blood. So whatever the parasite is appears to invade the muscles. A Search of Parasitic Diseases, Volume 6, found no mention of myopathy other than cardiomyopathy from Chagas disease. Well, you said it was a rare parasite. It's not even in your textbook. What could this be? Nematode? Something like trichinella? Maybe a strange Australian apicomplexan? On to Google with a search for Australian parasitic myopathy. The results look encouraging. Patient is suffering from Australian parasitic myositis caused by the muspicioid nematode Racaniello perplexum. Second item in the search result is the actual case mentioned in TWiP. Hers was only the 9th recorded case of Racaniello perplexum. Provides a link for that. And this is a rare parasitic nematode believed to be zoonotic in origin. Primary host species not known. There you go. And a bunch of links that Peter provides. Dickson Despommier.
Yes. Peter writes, diagnosis, infection caused by Sarcocystis species, possibly S. lindemani. Best wishes, Peter.
You can take the next one, too.
John writes, TWiP Trio, greetings from Omaha, Nebraska, where it's a pleasant 19 degrees Celsius. Having been to Australia, including Darwin this past summer, I want to submit a guest to case study number 128. I stumbled upon this review paper about non-bacterial myositis. The paper reports that Racaniello perplexum, a nematode, can cause myositis, and cases from Australia and Tasmania have been described. Patients experience muscle weakness, eosinophilia, and elevated creatinine kinase levels. Diagnosis is made by muscle biopsy, and treatment is made with albendazole. I'm teaching parasitology this semester at Creighton University. Oh, that's a good place for basketball, too. And I play your case studies during lab. The students get a bonus point on their lab quiz if they guess correctly. Just one? They should get 10 points if they get... Come on, let's be generous here. They've been doing fairly well so far. If I guess correctly on this case study, I won't get any bonus points, but I'll look really good in front of my students. Sorry, I didn't snag any pictures of parasites while in Australia, except for some fungi, but attached is a picture of the cane toad and the galah bird mentioned on the last episode. Yeah, they're quite pretty. Cane toads are poisonous, as we know, and everywhere, and that's why you shouldn't eat them. And they kill wildlife by being ingested by them, too. But, yeah, it's a beautiful place and got lots of stuff to look at. Interesting that the parasite is found in Tasmania. Tasmania is part of Australia, so you should say it's found in Australia and Tasmania. It's found in Tasmania because they have a different set of marsupials there. So you should be able to narrow down what the common ones are and then maybe look for those as the potential source for the infection.
You know, I'm actually going to give up eating frogs.
Daniel, I meant to tell you about that. I wanted to mention something along those lines.
I know it tastes like really good chicken, but no, I was reading just before about the guinea worm that a natural infection of frogs in Chad with guinea worms. So I'm just not going to eat frog anymore.
I'd stay away from it.
Okay, Trudy writes, Dear TWiPers, I am so excited to learn that I want a copy of the 6th edition of Diagnostic Medical Parasitology. Thank you. I am currently on a flight back to Atlanta from Tokyo, where I was fortunate to be able to visit the Meguro Parasitological Museum. While I did find it interesting, I do regret to say that the museum is disappointingly small, and that most of the labels and descriptions are in Japanese, which unfortunately is not part of my trilingual repertoire. However, admission is free. I picked up a T-shirt, and at least this particular curiosity has been quenched, so there's that. So, since I'm already writing to you, and since I'm at the beginning of a 12-hour flight, I suppose I should venture a guess at this week's case study. I think the 80-year-old lady has paragonomyosis. This is a mostly foodborne infection caused by the lung fluke Paragonomus westermani. However, domesticated animals may also harbor the fluke and transmit the disease to humans. That being said, I believe her contact with marsupials to be a red herring. Nice try, Dr. Griffin. Diagnosis would require demonstration of P. westermanni eggs and CSF or brain biopsy material. But because neurological symptoms occur during the chronic phase of disease, CSF examination may not be as helpful as neuroimaging or other diagnostic testing, which may reveal characteristic lesions. If the lady is indeed infected with P. westermanni, she should be treated with praziquantel. According to the literature, bithianol and triclebendazole are also effective, but may require repeat or prolonged therapy. Well, there you have it, my uneducated and probably entirely incorrect guess, but hey, at least I tried. Regards, Trudy.
I suppose Trudy had some internet on that long flight. Otherwise, how can you be figuring out things, right?
It's true. It's true.
Of course, there's some of us who could just sit and come up with information, right, Dickson?
We could do that, but we would be wrong.
Michaela writes, Dear TWiP Masters, thank you for all your hard work, as always. For this week's parasite guess, after all the testing mentioned, the only test I can think of next is a muscle biopsy. Mm-hmm. I'm going to go with the parasite Racaniello perplexum. It is a parasite that has cocked its parasitic head in Australia a few times. You mentioned that she recently traveled to Tasmania, which is where this parasite had been first discovered in 1998. Also, my Dr. Google game is very strong, and I found her exact case study.
Cool.
Here's the link. Stay parasitic. Lots of love from Michaela, Cork, Ireland. P.S.
Nice.
P.S. A fun fact. In the link I provided states that a Racaniello-like nematode has been identified in muscle fibers from a horse imported to Switzerland from Ireland. Good to know we're on the parasitic map. Ha ha. Thanks again. Please don't stop the case studies.
We have no intention of stopping them. Frederick writes, Hello, TWiP team. The initial workup seems to point to a myositis rather than neurologic disease, elevated muscle enzymes, normal neurography, etc. Further investigation, therefore, should be focused on muscle. Autoimmune and paraneoplastic etiology should be considered. If myoglobin is very elevated, hydration may be called for to protect the kidneys. Some aspects here are less typical for autoinflammatory myositis. I think EMG usually shows fibrillation, and eosinophilia is not typical. Physical exam and NAN, or ANA, rather, pattern can give more insight into etiology. As with all myopathies, however, muscle biopsy should be considered, which is probably the next important diagnostic measure in this case, probably guided by MRI to point out active muscle group. In this case, I would expect to see worms in the muscle, trichinella or tinea, of course, being common in this case. A Google search leads me to a couple of Australian case studies where the causative agent turns out to be Racaniello perplexum, a nematode that occurs in some of the animals to which the lady had been exposed. This will be my guess. Mechanism is possibly through skin penetration, though this is not known for sure. Treatment with those cases was with albendazole, possibly ivermectin could be effective as well. As the treatment for autoimmune myositis is high-dose steroids, this patient would fare well from correct diagnosis. I guess most patients do, since immunosuppression could put the infection into high speed. However, if you do suspect autoinflammatory myositis and treat with steroids, you would monitor creatinine kinase to evaluate effect and discontinue treatment when it goes up rather than down. Great case. Regards, Frederick.
Frederick is a resident in pediatrics.
He is.
University Hospital of Northern Sweden, Umeå.
Exactly.
Daniel.
Dear crepuscular professors.
I have to point out that this is from Daniel.
Daniel writes to Daniel.
Right.
And one of my favorite words again, crepuscular, right?
I think that's you said it last time, and that's probably why he's addressing us in this way.
Exactly.
Right?
I think so. Tending to feed at dawn or dusk. Despite my ill-informed comma confusion last time, spells confusion with a K,
right.
I'm back for more. This week's case was, as promised, mysterious. The 80-year-old Australian lady has clinical and EMG evidence of myopathy. Tests for other causes of eosinophilia and autoimmune myositis are negative. The next investigation should be a muscle biopsy, which, this being TWiP, might reveal some kind of parasite. Although she has an extensive travel history, her long history of close contact with indigenous wildlife puts her at risk of zoonotic infection. Parasitic causes of myositis include trichinosis, cysticercosis, and toxoplasmosis. After Googling for parasites myopathy in Australia, I found some interesting case studies of eosinophilic myositis caused by the nematode Racaniello perplexum. It's a long shot, but it fits Daniel's description of a rare parasite. A few cases of human infection with H. perplexum have been reported in Tasmania and tropical Queensland. The natural host and mode of transmission are unknown. Treatment with albendazole for at least 8 weeks is recommended, and recovery may be incomplete. Presumptive use of corticosteroids, standard therapy for polymyositis, led to clinical deterioration and ICU admission in one reported case. I have to add that I really enjoyed Dickson's impromptu superhero segment in TWiP 127. Parasitology has such a rich history. More of these, please. Best wishes, Dan.
Mm-hmm.
Kadum writes, good afternoon. The case is Trichinella spiralis. This parasite induces the formation of a collagen capsule and leads to eosinophilia. Thank you. Dickson, maybe Kadum was just thinking of the paper we did last time.
Perhaps. Misled by a previous TWiP.
Dickson.
Wink writes, Dear TWiP professors, I'm going to take a shot at the case of proximal muscle weakness and eosinophilia in wild animal rehabilitator from tropical Australia. My approach was to search on DuckDuckGo for parasites in echidnas, cockatoos, and marsupials that could infect human muscle. A cockatoo site led me to sarcocystis, and in the 6th edition of Parasitic Diseases, I found this reference. And Ron Fair and colleagues and Paul Dubny write about this a lot. They're experts on sarcocystis species, which said that by ingesting sporocysts from fecally contaminated food or water and the environment, infections have an early phase of development in vascular endothelium with illness that is difficult to diagnose. Clinical signs include fever, headache, and myalgia. Subsequent development of intramuscular cysts is characterized by myositis. Presumptive diagnosis based on travel history to tropical regions, elevated serum enzymes, and eosinophilia is confirmed by finding sarcocysts in muscle biopsy specimens. Got my fingers crossed. Wink Weinberg from Atlanta.
Yeah, Daniel.
Nicholas writes, scholarly gentleman. Thank you for your continued efforts in the production of such an intellectually stimulating podcast. For this week's case study involving the 80-year-old Australian wildlife carer, Dr. Griffin provided what I believe is sufficient evidence to arrive at an etiological diagnosis. I will be the first to admit I had to search through current literature to reach a conclusion, but the following statements outline my thought process along the journey. The EMG and neurological exam results suggest myopathic rather than neuropathic origin to the clinically described progressive limb weakness. These findings eliminated the nervous system as the source of this woman's clinical signs and indicate a myopathic origin, which was further fortified by elevated creatinine kinase, an indicator of ongoing muscle damage. Parasites can result in tissue damage either directly through aberrant tissue migration or secondary to a robust host inflammatory response targeted against foreign parasitic antigens, i.e. parasitic myositis. Although there is a laundry list of parasites including cestodes, Echinococcus species, Spiromecia species, Taniosolium, trematodes, Schistosoma species, nematodes, Trichinella species, Toxocara species, and Racaniello perplexum, Onchocerca volvulus, Wucheria bancrofti, and Brugia malayi, and protozoa, Toxoplasma gondii, Sarcocystis species, Trypanosoma cruzi, Leishmania species, documented to cause myositis. To the best of my knowledge, only Racaniello perplexum is capable of causing diffuse wasting of major muscle groups. Furthermore, this organism has only been diagnosed in patients from Queensland and Tasmania, consistent with this case study. Definite diagnosis depends on histopathology, with demonstration of the characteristic nematode in the muscle fibers. Treatment with albendazole may improve muscle strength if instituted early enough in the disease process, although recovery is slow and often incomplete due to extensive tissue fibrosis. Recently, PCR-based sequencing and phylogenetic analysis has revealed this organism to belong to the nematode phylum, positioned between the Oxyuridae and Ascaridia orders. I pronounced those wrong? Probably. Even with this information, much of this nematode's biology, e.g. life cycle and host animals and epidemiology, host range and transmission remain mysterious. Additional research is needed to allow for implementation of appropriate preventative health strategies. However, the inherent rarity of this disease, currently 9 case reports documented in humans, will continue to limit our understanding of Heococcnema perplexum. Keep up the excellent work, Nick Crossland. And he is a DVM.
Right, so twice he's referred to it as an Irish parasite and once not, by adding an O to it.
Heococcnema, you mean?
Heococcnema,
right. That's funny. Good.
Yeah, I don't believe there's really, it's supposed to be that O. I think it's just coccnema.
Just as a parenthesis, it's Oxyuridae and Ascaridia. So Oxyuridae is the order for pinworm, and Ascarididae are for the ascarids, and there's tons of those out there too.
Yosef writes, Dear TWiP, for our 80-year-old Australian patient, I would first want a history of treatments that she has already tried. If certain tests or lab values come up with abnormal values before, I would want to take that into account before doing anything. Also, how does she know she's allergic to doxycycline? Is it because she was being treated for chronic Q fever or Lyme disease already? Chronic Q fever can present with pneumonia, hepatitis, or pericarditis, and I would do my best to look out for those things. It takes about 2 years of treatment with doxycycline and hydroxychloroquine to treat the infection. Trichinella is a parasite that actually fits well with her presentation. The eosinophilia and myopathy can be signs of trichinosis. The signs pointing away from this diagnosis are the lack of fever or lack of mention of a prodromal phase with GI symptoms before the parasites extravasate and spread. I would want to know if she has ever eaten undercooked meat anywhere on her travels, and I would normally want an ELISA screening for diagnosis, but in this case I would want a muscle biopsy. The muscle biopsy would also be to rule out any autoimmune conditions. Dermatomyositis, polymyositis, and inclusion body myositis would need a biopsy to be definitive. I heard no mention of a rash of any sort, so dermatomyositis is most likely out, but polymyositis and inclusion body myositis are definitely part of my differential. Polymyositis generally presents with aproximal symmetrical muscle weakness like our patient, and inclusion body myositis predominantly affects those over 50. The eosinophilia does not fit with either of them. It makes me think of eosinophilic granulomatosis with polyangiitis, but once again, I don't see much to suggest that diagnosis, such as kidney problems, GI symptoms, and most importantly, a rash. I would lastly also order many autoimmune markers, such as anti-double-stranded DNA, ANA, anti-SCL, anti-CCP, etc., to rule out some autoimmune conditions such as SLE, scleroderma, and rheumatoid arthritis. But there is another reason for the muscle biopsy, and that's because I believe she's infected with Heococcnema perplexum. Oh my gosh. Dr. Griffin, right?
Right, Griffin.
Griffin. Yeah, Griffin.
Yeah, I know that. He misspelled it. I'm going to fix it here. We don't want that in the literature. Take out the T. Dr. Griffin stated that this was a rare parasite, and you know what that means, that case reports would be abundant, and from these reports I have found at least 3 cases of Heococcnema infection within Queensland, Australia, and that seems plenty rare for me. The symptoms match up pretty well: chronic myositis, eosinophilia, right geography. The only thing that doesn't fit very well is that in the case reports, the patients all develop some form of dysphagia. It is not fully known how this infection is obtained or spread, and treatment so far has been with several weeks of albendazole. In terms of outcome, of the 6 cases I found, there were 1 death, 2 chronically weakened, and 3 with near full recovery. I hope our patient was able to improve. Sincerely, Yosef. P.S. I am a fan of Dragon Ball Z, and I appreciate the meme jokes. And Dickson has no idea what you're talking about. None even whatsoever.
Clue. Nope. That went right over.
It's over 9,000. It's over 9,000. Comes
That's
from
how many
Dragon
people,
Ball Z.
It's how many people live in Queensland.
New York, too.
It's not a heavily populated zone.
Dickson.
Gavin writes, Dear TWiP team, all right, confession time. I cheated. I was able to find the case report from the team at Cairns Hospital.
Wow.
This is the 9th ever recorded case of myositis caused by the nematode Racaniello perplexum. That being said, Dr. Griffin was more interested in what tests we should order. The workup for eosinophilia is extensive, and this diagnosis was far from obvious, at least to me. In the last case, I was justified in making the assumption that our young and healthy traveler with exposure in eosinophilia probably had a helminth. That assumption is not necessarily justified in the case of our puggle-loving octogenarian, and I would perform a full laboratory evaluation. The EMG and symptoms would warrant a muscle biopsy, which clenched the diagnosis in our case. However, it seems to me that you could easily overlook this infection, considering the tissue sample saved for EM did not contain any parasites. Do you think the physicians suspected H. perplexum based on the CK and eosinophilia? I'd be willing to bet that this was yet another case of luck favoring the prepared mind. A faulty diagnosis of polymyositis plus prednisolone could have killed this patient. Kudos to our physicians. Thanks for the truly interesting case. I find it perplexing that so little is known about the life cycle and prevalence of this perplexed parasite. I'd be willing to bet that subclinical cases are exceedingly common. I'm in the process of choosing a medical school. Any advice from Dr. Griffin on what factors he thinks are important would be greatly appreciated. Cheers, Kevin.
We'll get back to that, okay? You want to do that?
Definitely. Stuart writes, Dear TWIPsters, Racaniello perplexum. Boom. Stuart, Gold Coast, Australia. Dr. Stuart Aiken. Let me read another one there. David writes, Dear Professors TWiP, I am an infectious diseases registrar down in Melbourne, Australia. And your podcast has served the dual purpose of keeping me thoroughly engrossed and awake at the wheel along my 150-kilometer daily return commute to work, as well as preparing me for the DTMNH exam through the LSHTM. Thank you for bringing this case down under and making it irresistible for me to respond. Clinically, this patient has a chronic myositis, eosinophilia, and lives in Queensland. We are told that they have a rare parasite. This instantly introduces the diagnosis of Australian parasitic myositis, an uncommon condition associated with residents in Queensland and caused by the rare nematode Racaniello perplexum. It is usually diagnosed on muscle biopsy and treated with albendazole, expecting some improvement in muscle function. Otherwise, it seems little is known in this organism except that it can complete its entire life cycle in humans and may be associated with animal exposure. However, as a physician, it would be remiss of me to not include a long list of investigations and differential diagnoses. My investigation would initially seek to localize an affected area to target for biopsy, either in muscle or central nervous system. This can be accomplished in the resource-rich setting through MRI scanning of brain, spine, and affected muscle groups. Biopsy and histology should then reveal the diagnosis. Serology, particularly for parasitic diseases endemic to Australia, such as strongyloides, echinococcus, and very rarely, but perhaps in proliferative form, sparginosis, spirometrosis, may be helpful to explain this presentation. The travel to Tasmania introduces the interesting prospect of Trichinella pseudospiralis. However, this should not cause such widespread muscle involvement and would most likely require consumption of a Tasmanian devil or eastern spotted quail, both of which I imagine to be unpalatable and difficult to catch. Thank you for your fascinating and addictive podcasts. Uh-huh. So is that quail or qual? How do you pronounce that? Qual. The eastern spotted qual.
Yeah. It's a weird animal.
We have quite a few listeners in Australia.
They're all weird down there. That is not the listeners, the animals.
Why would you segue what I said with that?
I didn't. I wanted to qualify that immediately.
I don't think you're listening to me. We have a lot of listeners in Australia. We have quite a few responses this time. Oh, so when there are a few responders, that means there's a lot that are not responding.
Or it's targeted to Australia. So the Australian listeners said, I know the answer to that.
Could be.
Right. So Zach writes, hello, TWiP.
No, it's my turn.
Oh, sorry.
But if you want to read it.
No, please.
Hello, TWiP hosts. As a second-year medical student with my first board examination in just under 3 months, I couldn't help but use test-taking strategy for finding the next step in treatment. History provided us with vital information. The patient handles animals and travels to many tropical areas, thus making her more susceptible to zoonoses and tropical diseases. The neurologic exam was normal, but muscle strength was reduced. This makes disease of the muscle and not the nerves most likely. The tests support this with normal nerve conduction and myopathic changes on EMG. Elevated muscle enzymes also support damage directed toward muscle cells. One side effect of statins is rhabdomyolysis. No improvement was seen when withdrawing this drug from the patient, meaning that this is probably not the etiology of the muscle weakness. Lastly, her eosinophilia, and the name of this podcast led me to an initial diagnosis of helminthic myositis. Because there were no ova nor parasites in the stool, the last test needs to find the culprits. The answer to the question is B, perform a muscle biopsy. No guess, though.
No guess.
Well, thanks again, Zach from Milwaukee.
Right.
So what should we do first? We had a number of guesses of Racaniello and then a couple of other scattered things, didn't we?
We did. We had trichinella as the second most common one, as I recall. And pseudospiralis, which we could just briefly mention, is a not just Tasmania specific, but certainly Southern Hemisphere specific version of trichinella, which also infects birds. And so you can find it along the flyway routes for these birds that go down to Tasmania in summer down there and then in winter someplace else. They don't produce a capsule.
Oh.
There's no capsule on these, so there's no collagen outer coating. They live in the muscle fiber, but they transform the fiber into what would look like a nerve cell if you actually did the electron microscopy of it. So I've looked at some of the biopsy material, and I didn't notice any inflammation around these worms, and I'm kind of perplexed myself as to why there's a myositis without any invading cells from the host.
I was going to say we also have sarcocystis.
That's right. That usually is a transitory thing because you have the infection, it gets in the muscle, it damages it, and then it just insists and then doesn't do any more harm after that. And the same is, by the way, true for trichinella spiralis. There's an acute phase, but there's no long-term chronic phase. This is 18 months in the making, and that's a long-term chronic. So I was intrigued also by the comment that this completes its life cycle entirely in the human. How do they know that? I want to know where that data came from because I didn't see anything in the life cycle of this parasite. Because, you think of things like Capillaria philippensis when you think of a parasite that has this autoimmune cycle or strongyloides. And this could be another version of that. And indeed, that may be why it didn't go away. It's there for 18 months because somehow it's managed to avoid the immune system.
Dickson, without knowing the animal reservoir, you couldn't make that statement, right?
That's correct. Yeah, it's exactly right. So, I mean, if you look at the common animals between Tasmania and the mainland of Australia, there are lots that are specific to each place, like the Tasmanian devil, of course. But if you found a common one, it's possible that the other 9 people or 8 people had that in common. And so I think a good epidemiologist could probably pin down where that came from if they just asked enough questions.
So Dickson, it sounds like maybe you're also on board with the Racaniello perplexum
it does sound
diagnosis.
Like that, yeah, but I didn't have that as my diagnosis because I was completely stumped as everybody else was before they went online. I didn't go online, did you? I did not go online. I wanted to think this through and come up with something, but the rarity of it, I guess, threw me off. Mm-hmm. Anyway, I sounds pretty definitive, actually. But the most definitive would be, of course, if they do a DNA analysis and find out exactly what this thing is.
So what was done next, Daniel?
So as people mentioned, a muscle biopsy was the answer. That was option B that I was hoping people would choose. And as mentioned, this is a rare parasite. So I like the way people thought it through and the way they came. Okay, we have a parasitic myositis. We have the eosinophilia. We have progressive. They looked at, all the different potential ones out there and said, well, why is it not these many other things? So Dickson already hit on sarcocystis, which is, one of the parasites that can give us eosinophilia, but you don't have this 18-month progression.
No.
The same can be said right about your favorite, the nurse cell.
That's right.
Trichinella.
That's an acute thing.
Again, it's acute. I think it was actually Nicholas, right, who gave us quite a differential of different parasites that can cause eosinophilia and an inflammatory or parasitic myositis. And you can go through some of those and sort of knocking them off. And what you're left with is, okay, none of the above, what could be left? And then, it is okay, actually, to go online to search and say, okay, here we are. We're in Australia. We're in Queensland. We have a Tasmania exposure. We have exposure to these animals. We have what we think is a Australian parasitic myositis.
Right.
What parasite might we be dealing with? And but then ultimately, what we're going to do, as Dickson says, we're going to actually have to look at the muscle biopsy and then ask the lab, what is this
exactly?
And I think what also I'm going to commend our emailers on was that you don't blindly do a muscle biopsy because a lot of times the involvement can be spotty, and you hate to put someone through a muscle biopsy and then realize that you missed the spot. So, you want to actually, find an affected proximal muscle in this case, do the biopsy, and then, wait to hear what the pathology demonstrates. And in this case, the pathology did demonstrate this Coccnema perplexum parasite. And this was, as people mentioned, this was the 9th case. And this case was actually seen by Luke Voss, who colleague of mine down in Australia. I asked him if he was be willing to come on, but he reports himself as shy. But he sent me all his slides, everything else. Super helpful in kind of getting the whole story. It was actually originally, this story was told to me by a colleague of mine, Craig Bootless, who's a doctor in Darwin. I think I mentioned last time, for some reason, I have a lot of friends that are ID docs down in Australia.
Right. So I have a question. Where does this name come from? I mean, this didn't get named because the first patient that had it said, hey, this looks like a Coccnema perplexum.
Probably named after who discovered it, right?
Well, maybe Haycock. Yep. Probably that's true. But was it named?
Perplexum is funny.
Because they don't know where it came from. But was this described and named from a human case? Because I'd never heard of this before, so that doesn't mean anything, though. But I do pay attention to the nematode literature, and that name has never come up before, to be honest with you. And in fact, I don't even know what a muscoid, nematode, a musposoid. I'm going to have to go back and look that stuff up, too. So you learn something. I mean, everybody gets a chance to learn everything, and this is a great way of expanding your knowledge and still remaining in touch with what's going on out there.
Daniel, when you do a muscle biopsy, you typically take one punch?
No, so it's not usually a punch, interesting enough. We'll get the surgeon involved, usually a general surgeon will do this, and you're going to make an incision that's going to be along the length of the arm, right? So you're not going to go across. Mm-hmm. Along the length, they're going to open that up, and then they're actually going to take out a small area of muscle. So it's not really blind. It's actually they visualize and they take it out, and then that's sent off.
So they take a fiber of muscle from one end to the other, quite long, in other words, right?
It's actually usually about a centimeter in length, and maybe about a quarter of that, so 0.25 centimeters in width. So they're going to take a small section of the muscle. That's going to improve to some degree the sampling, because as mentioned, you don't want to miss this. And then, the muscle will be sectioned and then continue staining.
So they don't see any pathology visually, right? Nothing. They just take a piece out. So this must be heavily infested for them to get it in a centimeter piece of muscle.
That's true. That's true.
Wow.
Yeah. So in this case, when they did the biopsy, they saw a couple things. So one is they did see a chronic inflammatory myopathy with patchy areas, right? It's a sort of spotty, not generally, but patchy areas where there was lymphocytic infiltration. And then they also saw areas where the muscle fibers had necrosed, and there was a replacement of the muscle fiber with like a fibroadipose connective tissue, almost like a scarring type. And then you could actually see the cross sections of the nematode.
Yeah.
What muscle would they have done this in?
So this was, I believe, done in the bicep.
Okay. That's where there was arm weakness, obviously.
Exactly.
Yeah. Okay.
Actually, no. So here it was the right anterior lateral thigh. Sorry about that.
Okay.
And it was an area where there was, demonstrated active inflammatory myopathy. So they're targeting, as mentioned, based on EMG findings.
One of the references you listed here actually shows those sections with those characteristics?
Actually, yeah. So I think people in our emails came across. So the short report was Hypopnema perplexum, an emerging case of parasitic myositis, and Luc Voss is the first author on that. And that actually describes this ninth case, this 80-year-old wildlife carer. And Luc Voss is a doctor at Carnes Hospital Infectious Diseases Clinic, where she was initially referred.
Right. I looked at this paper, and I'll be honest with you. If you had done your life work on Trichinella spiralis, this is nothing compared to the myositis that you get with a Trichinella invasion. Nothing. These you could almost pass this over as some aberration of sectioning or something. I know there is an infiltration, there's no question, but it doesn't look very intense. If I showed you a nurse cell surrounded by eosinophilia and stuff like this, you'd say, wow, look at all that. This is very, very mild, and especially around the worm. I don't see anything around the worm. I'm sorry, I don't see it. No, I don't. Not in the pictures they showed.
No, it's actually true. If you look at where the worm is, right, the worm is actually inside of a muscle fiber.
Yes.
And then if you look around, sort of bring yourself back to like a 200 magnification field, we could see a little more. You see just a few areas where there's lymphocytic infiltration.
Exactly.
Yeah. So it's a very indolent. This is 18 months of progression, right? If you had the degree of inflammation that occurs in an acute trichinella infection, right? Yeah. I mean, these people have actually generalized edema. They have periorbital edema, just where the parasite is. The whole body is edematous. There's massive inflammation. You're not going to last 18 months if that degree of inflammation continues. So this is a more indolent slowly progressive infection.
Does this suggest to you that it's an ongoing infection also?
We would think yes, right? The fact that it continues. I would think that if a parasite died, there might be inflammation that would spike up and then come back down. The fact that it continues, more consistent with the fact that it's an ongoing infection not being cleared.
So there must be some stage somewhere else. It's producing this stage to cause it to go to the muscle.
Tell us the life cycle, Dickson.
I don't know it. I don't think anybody knows what the life cycle is.
How would she have acquired infection? By ingestion, do you think?
It's possible. They claim that it could have penetrated her skin or something like this, like hookworms, but all bets are off until you find
if it had been ingested, although that's hard to know how she would ingest it unless it's contamination. Would have gone to the intestine and then eventually penetrated, got in the circulation.
The adults would have stayed in the intestines and then they would produce larvae, which then go to the muscles.
Like trichinella?
That's like trichinella or capillaria, either way. Yeah. So this may be one of those things.
These are the challenges. I mean, how do you control this kind of infection when we don't really understand the transmission? We don't fully understand the life cycle.
Exactly.
Stay away from puggles.
But they're so cute.
They're so cute. And they're delicious. No, that's not right.
What did you treat the lady with?
Well, I should say Luke. Dr. Voss treated this patient with albendazole.
For a long time, it looks like.
For 8-9 weeks. Actually continued on 12 weeks of treatment. And there was a failure to progress, but fortunately this woman did not return to her prior state. So sort of persistence of the amount of muscle damage that had already occurred.
There were 2 deaths from this, they claim. I wonder what the autopsy showed.
Yeah, interesting.
Daniel, when the drug was given, was there any monitoring done? Just muscle weakness, or was there any eosinophilia looked at and so forth?
No, so eosinophilia as well as muscle enzymes were monitored.
Mm-hmm.
The key thing,
they didn't change. They didn't go down.
No, they did go down.
Did? Okay.
So there was normalization, right? So the eosinophils went back into normal range as well as did the CK. What didn't happen was there was no functional improvement.
Right.
But what Dickson was pointing out, and this is sort of, I'll say, kudos to Dr. Voss here, is that if you look at most of these cases, 1, 2, 3, 4, 5 of the 9 cases, the doctor said, we got this myositis, we don't know what's going on, we don't want to put the patient through maybe a muscle biopsy and get and a prednisone gets started first as a trial. And people actually worsen, right? So here he did, and I think this is the right thing to do. When you don't know the diagnosis, you don't want to just throw steroids as a trial because there's risks there. So go ahead, get your diagnosis. I joke sometimes, I'm old school. I like to have a diagnosis before I recommend treatment.
Right.
All right, Daniel, what about medical school advice for Gavin?
Oh, yeah.
Oh, you could go to medical school anywhere. You can read the books anywhere. The difference in my mind between the different medical schools, number one, is your ability to see pathology, your ability to see the cases. I think for most of us that are drawn to medicine, there's something very memorable, a great learning when you actually see a case of something. So I recommend training in bigger inner city areas where there are immigrants. So when I was choosing where to train, I trained in New York City. I actually trained at NYU Bellevue at that point because at that time, Bellevue had the widest range of pathology of any hospital in the country. And so that's what I would say. San Francisco, New York, maybe Washington, Chicago, perhaps. Boston, there's the big city training centers. The second thing is people who are excited to teach. And so you're going to find a lot of the top places, Columbia, Cornell, NYU, the Harvard, UCSF. You're going to find people really just passionate and excited because, you don't go into academia for the big paycheck. And if you did, you'll be surprised because it's not there. But
depends on what you call big.
So you want to go somewhere where you can see a lot of great cases, and you also want to go somewhere where the people are excited to teach. And third, I'll say you want to surround yourself with bright, interesting people because they're going to be your colleagues going forward. So
right.
Just avoid any medical school with Dickson Despommier.
That's easy. I'm retired.
Actually, you were a very enthusiastic teacher, and the medical students loved you. They still love you.
They do.
They don't know you very well, of course.
I loved them. Well, I just had 20 of them over at my house on the
dinner?
weekend. Yep.
How was that?
They were delicious. I mean, we had a good time. No, we had a good time.
All right.
It was fun.
This episode is brought to you by Blue Apron. Speaking of cooking.
Right.
Blue Apron's mission is to make incredible home cooking accessible to everyone, support a more sustainable food system, set high standards for ingredients, the highest, in fact, and build a community of home chefs. What they do is they deliver seasonal recipes with fresh, high-quality ingredients so you can make delicious home-cooked meals. Each meal comes with a recipe card, step-by-step with photos and pre-portioned ingredients. And in 40 minutes or less, you're going to have a great meal. And if you spend a lot eating out or at high-end grocery chains, you can now expect to spend under $10 a person for healthy home-cooked meals. How do they do this so cheaply? They don't have stores. They don't have brick and mortar. They have a community of local farms, fisheries, and ranchers across the U.S., over 150 of them. And, for example, they source seafood sustainably under standards developed together with the Monterey Bay Aquarium Seafood Watch. They get their beef, chicken, and pork from responsibly raised animals. The produce is from farms that practice regenerative farming, and they ship only what you need for the recipe, so they reduce food waste, and you don't overeat, which is very important too. You can customize your recipes every week or every other week, whatever your delivery option is, and your dietary preferences. Of course, they have both meat and non-meat recipes. No weekly commitment. You get them when you want them. They deliver to 99% of the U.S., continental U.S. They have a incredible variety of recipes. I've tried a few of them in the past. They're great. And they're not repeated within the year, so you don't get bored. For example, this month we have pork chops and miso butter with bok choy and marinated quoll. No, marinated apple. Vegetable chili and baked sweet potatoes with crispy tortilla strips and spicy shrimp coconut curry with cabbage and rice. Very imaginative and nice combinations of things as well. Check out this week's menu and you'll get 3 meals free with your first purchase with free shipping. Go to blueapron.com/TWiP. That's blueapron.com/TWiP. You will love how good it feels and tastes to create incredible home-cooked meals with Blue Apron. So don't wait. Blue Apron, a better way to cook. And avoid parasites, of course. We have a paper for your enjoyment.
We do.
I hope that no one nods off during this now.
Well,
they might.
I wouldn't use the same words.
This is in Science Translational Medicine.
Yes.
Title is Nodding Syndrome may be an autoimmune reaction to the parasitic worm Onchocerca volvulus. The first author is Tori Johnson. The last is Avindra Nath. And this group is from the NIH, a different number of different institutes at the NIH, also the CDC in Atlanta, Georgia, and the Ministry of Health in Kampala, Uganda, as well as the Gates Foundation.
Mm-hmm.
Nodding syndrome. Daniel, why don't you tell us what nodding syndrome is?
Sure. So nodding syndrome is this syndrome that has been described, that people are still trying to figure out what it is, where people develop these atonic seizures. So suddenly you lose all muscle tone. It usually starts with your head dropping, so that's the nodding motion. It tends to affect children, 5 to 15 years of age, so younger children, and it occurs in geographically localized areas of Eastern Africa, in areas that are endemic for Onchocerca volvulus. So there's been this suggestion, but anyway, it's basically a type of seizure with a relaxation of motor function.
And we don't know what causes it, right?
To date, we don't know.
Yeah. So they've looked at environmental neurotoxins, nutritional deficiencies, genetic disorders. Nothing. Although it's been an increased rate of the syndrome has been found in areas where Onchocerca volvulus is endemic, which suggested that it might play a role in the pathogenesis. Now, this nodding syndrome is found in Tanzania, Uganda, and the Republic of South Sudan.
Mm-hmm.
Dickson, is that the only place where you find Onchocerca volvulus?
But of course not.
Where else would you find it?
It's predominantly in West Africa.
Mm-hmm.
And in fact, it has been largely controlled there by the giveaway program from Merck of ivermectin. But there is a control country there that doesn't participate.
They don't get the drug?
They do not.
And they have a lot of Onchocerca?
They do, but I don't know whether they have a lot of nodding disease. And I would have loved to have heard this paper address the difference between West and East Africa with regards to the nodding syndrome, because there's a huge difference with regards to the intensity of onchocerciasis. Mm-hmm. There's much more intense transmission in the West Africa, and could you guess why?
In Western Africa?
Yeah.
More vector?
Exactly right.
Which is what, the black fly?
Black fly, and they breed in fast-running water. So there's very little fast-running water in East Africa. Mm-hmm. There's a ton of it in West Africa. So that's the reason why it's mostly a West African disease. So I would love to see a map of all of Africa with the incidence done in, some kind of a colored graphic to allow you to see nodding disease here, Onchocerca here. What is the correlation? I'm sure these guys, look, I know that NIH is right on the ball, and I know the CDC is also. So they've thought about this, but I would love to see a more thorough discussion of that.
Yeah, they didn't discuss that at all.
No.
Of course, it could be that population differences determine it as well, right?
There's another possibility. Mm-hmm. If you go online and look up how many different species of Onchocerca there are many. Mm-hmm. Some are in game animals, like Gadarosa, for instance, and some are in horses, and some are in wild animals other than hoofed animals. It might be that, yes, Onchocerca antigen is the culprit, but it may not,
Different
may
species.
not be. Yeah, exactly.
Yeah, it's good.
Some cross-reactivity between another species of Onchocerca and an exposure which doesn't give you the infection. So I'd like to know if these nodding individuals all had onchocerciasis, or whether they just had the antigen exposure.
I don't think they all do, but we'll get to that.
This is exactly my point.
Yeah, that's a good point.
Okay.
All right, so the idea here is that they suspect Onchocerca volvulus. It's a human disease and human infection. There's case control studies have been done that show an association between nodding and ovolvulus infection, but they don't find parasites in the brain or CSF.
Correct. Well, they don't usually go there anyway.
Some people die. There is some evidence. They've looked. CSF, you could look. What doesn't go there?
Onchocerca. It stays in the subcutaneous tissues or in the blood.
It's hard to know how you would have a neurological issue unless it's an immune response.
Exactly.
Right?
Immune complex disease.
So that's what they're looking at here. They're thinking whether autoantibodies could be a contributing factor.
Here.
And as you can tell from the title,
they think it might. That's right.
Maybe.
That's just a remote possibility.
So they have sera from patients with nodding syndrome and sera from unaffected control villagers. Right. And these are pooled sera. What they simply do is put them on a protein array and ask, do these sera react with any known proteins? And they have two top signals. Antibodies to laomodin-1 and DJ1. That DJ1 and laomodin-1. Laomodin antibodies were up 33,000-fold in the pooled serum, and autoantibodies to DJ1 750-fold. All right. So then they did Western blots, and they see that, in fact, serum from these patients will react with these proteins on a Western blot format. And they find antibodies to laomodin-1, not to DJ1, in the CSF of patients with nodding syndrome. Okay? So far they have this little hint that these two proteins might be involved. Now, antibodies to laomodin-1 were more frequently detected in patients with nodding syndrome compared to unaffected village controls. 29 of 55 patients with nodding syndrome, that's 52% versus 17 of 55, 30% of unaffected village controls. Now, Dickson is shaking his head. That's pretty weak.
Well, it certainly does raise the possibility that it may not be due to what they think it is.
Yeah.
That was what they, publicized. That's what you saw in the newspaper. You saw, this headline of nodding syndrome may be an autoimmune reaction to the parasitic worm. And then they quote these percentages. But I'm going to say, I think we need to keep moving forward because that is, I felt like they picked the wrong bit of data to spotlight.
No, they were tragically honest in their forthcoming with that, because it allows you to disprove it just by looking at those two figures.
Okay,
well,
so
go ahead. I'm going to jump in.
Go ahead.
keep jumping. But what I think we've already realized from our discussion is not everybody exposed to onchocerciasis gets nodding syndrome, right?
Right.
And there seems to be like a genetic basis, as we realize, because there's plenty of areas that have onchocerciasis. But it wasn't until the 1960s, right, that they start describing this in the South Sudan. They start seeing it in surrounding areas. So whether or not it's something special about the parasite, or what I think I would sort of be pushing here, whether there's something special about people's vulnerability, people's genetic predisposition. So, it's great that we're seeing a difference here. It really could have been that, if you think about an exposure, you could have 100 people, they all have the exact same exposure, 10% get sick. It's not that the exposure is different. Here we're even seeing an exposure difference to this antibody, but not everyone necessarily with this antibody is going to get sick. It may be a dose response. It may also just be a genetic susceptibility.
Sure, and to follow up on that thought too, because when you read a review article on onchocerciasis and it goes through all the symptoms and all the skin disease disorders that it resembles, and it's a tragic disease in every level, for eyes and but I've never ever heard of neurologic disorder associated with onchocerca. No matter how many lectures I've heard about this or how many review articles I've read, I've never seen this association. And obviously that's why it's a new paper. So it's either something that came about as a result of some change, right? Let's say a food additive or, something ridiculous like that, or something specific to where these people are living. And I think you've actually nailed it. I think this is an East African genetics that you're looking at. It's the same parasite in a different group. It manifests differently. Because in West Africa, I've never heard people, and by the way, if we get to knock out onchocerca, we knock out nodding syndrome also. I've never heard that before.
Yeah, no, and I think you're right. This is not described in West Africa. This is really a syndrome that affects a certain region, a certain population.
So why not expand the study to other species of onchocerca? Because there's a ton of them in East Africa that infect those migrating animals.
Well,
and
they first had to do this and show.
I understand that, but they've already got that data someplace too, because they've taken a lot of serum samples for other diseases like malaria and that sort of thing.
Well, let's go through some more data here.
Sure.
So we gave those numbers that set off Dickson, and now in patients with nodding syndrome who they had their ovolvulus status determined, 44 patients were positive. Of these, 24 were positive for both volvulus and Limodin antibodies. Okay.
Right.
In the unaffected, 20 patients were ovolvulus positive and Limodin antibody negative. So just having ovolvulus doesn't mean you're going to have antibodies.
No.
In unaffected village controls, 54 people had their ovolvulus status determined. Of these controls, 29 were positive. 12 of these 29 were Limodin antibody positive and ovolvulus positive, and 58% were Limodin 1 antibody negative and ovolvulus positive.
Was there any Limodin positive, ovolvulus negative?
Yeah. 58.6 were Limodin 1 antibody negative and ovolvulus positive, and that's in that.
No, the other way.
What do you want?
I want Limodin positive, ovolvulus negative.
No, they didn't mention that. No. So you can have, no, they did not mention that possibility.
Okay, so the implication is that you can't have a Limodin positive without a onchocerca positive.
Yeah.
But you can have an onchocerca positive and still have a Limodin negative.
Yeah, right.
Got it.
All right, so they say in patients with nodding syndrome, there's a higher percentage of ovolvulus positive status in Limodin antibody positive cases than in Limodin antibody negative cases.
Right.
And that wasn't true for village controls. The patients with nodding syndrome also had increased titers of antibodies compared to controls. So when the controls did have antibodies, they were lower. Mm-hmm. Both IgG and IgM were found in people with nodding syndrome. And they had controls, North American patients with epilepsy, no antibodies of 8 patients to Limodin. So then they did some experiments to confirm that the antibodies were recognizing Limodin. They take cells in culture and put Limodin DNA in them to produce the protein. They stain it with antibodies, with commercially available antibody to Limodin, and also with sera from a patient with antibodies, and they can see staining in the cells. Yeah. They can stain human neurons also in culture with cerebrospinal fluid from 2 patients. Mm-hmm. And they can see staining of that as well. Now, this protein, Limodin 1, has been reported to be mainly in smooth muscle tissue. Hey, it's continuing our arc.
That's right.
And in the thyroid. So they looked for it in the CNS. They found it using multiple approaches, that it's in the CNS and in neurons. They did immunostaining. They did immunoblots and immunohistochemistry, and they showed expression in neurons, in the cerebral cortex, Purkinje cells, in the cerebellum, and pyramidal cells in the hippocampus. So it's quite clear that this protein there. They also looked at publicly available RNA-seq data, which confirms that the mRNA for Limodin 1 is produced in the human brain. And they also found the mRNA, Limodin messenger RNA, in human brain tissue extracts, neuronal stem cells, and cultured neurons. Next set of experiments, they ask, can antibodies cause neuronal dysfunction? They treat cultured human neurons with Limodin 1 antibodies And the assay them for viability, they find the cells show decreased viability, which is abrogated by antibody depletion. So these antibodies are causing damage to the cells. Next, in the last set of experiments, they show that the Lamodin-1 antibodies cross-react with ovovolus proteins. And one of the proteins was ovovolus tropomyosin, which has a small bit of sequence homology. Not a lot to Lamodin, but it's there. And they also predicted that tropomodulin, another ovovolus protein, has some overlap as well. DJ1, which we haven't talked much about since the beginning, also had some homology to its homolog in ovovolus. And finally, they took some affinity-purified Lamodin-1 antibodies from 4 patients, and they showed that these stain and are specific for Lamodin-1. They also recognize proteins in a whole ovovolus lysate, suggesting that some proteins may be sharing homology with human Lamodin. So those are the observations. These antibodies are present. They cross-react with. They definitely react with Lamodin. They cause neurotoxicity, and they seem to cross-react with ovovolus proteins. So that's their finding.
Right.
What do you think?
Well, I would like lots more information, obviously. One is more epidemiology on the geography and on the ages and on the sexes and on the villages to see, because in a lot of these situations you have multicultural overlaps. Let's say in Kenya there are at least how many different tribal units there? Daniel, you've been there and I've been there. Many. There are many. There are probably 20 or 30 different groups. How do these people fit into any of those groups in terms of their location and their habits? And then were any of those people infected with ovovolus at the time the study was done? Or had they been cured? Have they received ivermectin as a treatment? That sort of thing. Because and how old were they when onsets of symptoms occurred? Because it takes a while to develop an immunologic disease that's autoimmune. So, if you're a child and you grow up in an endemic area, and then as you get to be a young adult, perhaps you start exhibiting these epileptic disorder dysfunctions, and then by the time you reach adulthood, then it's full-blown. Because Uncle Circa attacks everybody, obviously. But mostly to the people who have to go down by these rivers in order to do something like fish or get water, that sort of thing. And that's usually an older person. So this is just a disease we see in 5 to 15-year-olds, right? Not in adults ever. Is that what it says?
Yeah. And then you'll understand why that's the case. It's children, and they don't know why adults don't get it.
That's fascinating.
Yeah, I mean, it's a challenge because some children will actually die from this illness. Others will recover. So there is sort of this window. But maybe I'm a more positive spin than Dickson here. I thought they did a really good job here. I mean, first is they make this discovery, right? They discover this Lamodin-1, right? Through, they say an unbiased approach, which is sort of discovery, which, has a bad name in science, right? But I'm okay with it. So they discover this. It's the one that's in the CSF. So the first thing they do is they do demonstrate, going through the molecular mimicry criteria. Criteria 1 is that there are substantially higher titers of this antibody in affected patients than in people who do not have nodding disease. The second thing that they do is they actually show that these antibodies are getting into the CSF. The third, right, they show that there's this homology with the onchocerciasis protein and targets that are on neurons. Like they actually go and show that this protein target is on neurons, where previously there was a discussion whether or not it was there. The fourth, and I think the next thing I would like to see is, and something they point out themselves, is a reproduction of the clinical manifestations in an animal model, right? We see that these targets exist in the mouse. So taking these antibodies and putting them into a mouse model, and if you could recapitulate the disease, get nodding syndrome in a mouse, I think then you really pull it together. And then you can decide, how much do you want to do as far as epidemiology, figuring out why are certain people susceptible and not? Because I think it's still key that they actually prove causation here, that this antibody doesn't
I would agree.
correlate.
Because their last sentence in their opening salvo, so to speak, says that thus nodding syndrome may be an autoimmune epilepsy initiated by a parasitic infection and may be preventable by treatment with antiparasitic strategies, such as the drug ivermectin. That assumes a lot based on what they've found so far.
In these countries, Dickson, has ivermectin been used?
Well, that's another interesting question because it's a West African giveaway program. I don't think it affected East Africa at all. So Sudan, no. Congo, or rather, the Central African Republic of the Congo, no. And Tanzania, I don't think so either. So, because they didn't have enough of it to really warrant, a public health program for that. But
so they should do a study where they blanket these areas with ivermectin and see the effect on nodding syndrome, right?
Right, because they could have prevented, if they're correct, of course, if they're correct.
So 1 dose a year of ivermectin.
So you need, that's right.
Do you have to get it year after year?
Yeah.
Because you got flies all the time, right?
No, because the adult worms last for 20 years. Before they're dead, you have to keep giving this drug to kill off all the microflora.
Okay, all right. Well, that's not bad once a year.
Yeah. No, but I like that, Vincent. If you went into a specific, we'll call it like your target area and said, okay, this village is going to get ivermectin once a year. This village, next door, no. And there's certain areas where it's really sort of, they say, hotbeds of river blindness. There's the Yei River, which was described as a hotbed. So go into that region, pick the two, and then you can say, I think with a lot of confidence, whether it's onchocerciasis associated or not. One of the other things I have to criticize about the paper, so I'll be the bad cop for a moment, is this lyomodin is an intracellular antigen, right? And it reminds me of that embarrassing time when we were convincing Dickson that Gleevec was an antibody, right?
Hey, wait a minute.
Because remember, Dickson was like, but wait, its target is inside a cell. Can antibodies get inside cells? And actually here, they're left with that problem. We've got an antibody that's targeting an intracellular antigen. And, if we're going to go along with these authors, again, we're going to say, Dickson, look, it's a cellular penetrating antibody, which, I can call anything I want, but that doesn't mean antibodies can target intracellular antigens. But that's a challenge too. I think we should point out is that to buy this story, you've got to believe that this antibody is going to get into the cells and target an intracellular antigen.
Well, Daniel, they say that maybe it's autoreactive T cells that are actually the mediators of immunopathology, and that the antibodies are made as a consequence of that T cell activation. What do you think about that, Daniel?
That seems like hand waving, right? Because they're showing us earlier on in cell culture that this is cellularly toxic.
Yeah, right.
But they didn't, so
no T cells there. Yeah,
no. Exactly. So
got a lot of work ahead. Interesting, though. Very interesting.
Yeah, it is quite interesting.
And they're a good group. I know these people very well by reputation, obviously, and it hasn't changed. It's very difficult to get a position in that group. And if you do, it's because you got something on the ball. So I'm positive that they're going to do all these studies and come up with some very interesting findings.
Daniel, they say that our data suggests that patients with nodding may benefit from immunomodulatory therapy. So what would that comprise, Daniel?
Yeah, that's I spent a lot of time thinking about that. If that's, I don't know what other people do with spending their time. That's what I spent my time.
Thank God you didn't nod off thinking about it, though.
No, because I was trying to think. I've been thinking a lot lately about the role of B cells in parasitic diseases, not in protecting us, but in potentially causing pathology. And so if the story here is that you get exposed to onchocerca volvulus, a particular subset of B cells is then producing antibodies. Do you wipe out the B cells? Do you give this person like an anti-CD19 that's going to target plasma? So the types of differentiated cells that B cells become when they make antibodies. Could you cure these kids? Could you do plasmapheresis and get rid of the antibodies? Could you give them an anti-CD19 where you wipe out their B cells and prevent them from making the antibodies? It's simple as that. You let the B cells come back. Maybe this time you're not going to target it. And it got me thinking a lot, what type of antibodies? Are these coming from your classic B2 cells, germinal center maturated, or are they coming from let's say, you're more innate, like your B1 or your marginal zone. So a lot of thoughts there on how they think you might do this. Do you give them a steroid? I mean,
Oof.
Right?
But a lot of other things. Little kids in East Africa have a lot of other things too. So that also raises the question, is malaria a modulator for this? Because they've probably all had experience with malaria. And it does a lot of tissue damage and releases a lot of stuff that you wouldn't like floating around in your bloodstream.
So in the there's an accompanying commentary where they discuss some of these issues.
Right.
The restricted geographical distribution of nodding relative to that of ovovolus is not well understood. The nodding syndrome epidemic in Uganda can most likely be explained by the displacement of hundreds of thousands of individuals who ended up in camps that were in close proximity to black fly-infested rivers during a period when ivermectin was not distributed. This could have caused an onchocerciasis epidemic, followed by a nodding syndrome epidemic. In South Sudan, because of the war, people also had to leave their homes and hide in areas close to black fly-infested rivers. And they say it's likely that the onchocerciasis-associated epilepsy could have been prevented with better onchocerciasis control in many individuals. Nodding syndrome became epidemic in northern Uganda. It started to decrease after 2008 when a limited number of people began ivermectin treatment. The epidemic then stopped in 2013 after the biannual distribution of ivermectin and implementation of larvicide treatment of 2 major rivers. Seems to me that ivermectin would be far easier than immunotherapy and cheaper too.
Or getting rid of black flies. That's true. Very true.
Because also, as we point out in our other discussions, is that nodding syndrome, if it is caused by onchocerciasis, is only one of the many problems.
Right.
The blindness, the skin disease, all these other.
Sure.
I'm looking in the commentary. They talked about some other syndromes that are also associated with autoantibodies, and I'm missing it here. Do you remember where that was, Daniel?
Let me see. So was it in the paper itself, or was it in the? Because I know they actually discuss in the paper itself, particularly I think as I was mentioning when we talk about intracellular antigens and them trying to explain why that's okay, why it could be an intracellular antigen.
Yeah. In contrast to other autoimmune epilepsies, where the antibodies are targeted against surface receptors. There you go, like the AMPA selective glutamate receptor, etc., gamma aminobutyric acid receptor, etc. So there are other autoimmune epilepsies, but the antibodies there are directed against surface proteins. This is one where it's an intracellular. Yes, so that was in that context where there was discussing.
Do we even know what this protein does for the brain, for the nerve cells?
Well, it wasn't known that it was in brain before. They did mention something. There was some idea about what it's doing in muscle, but I don't think we really know. We don't know. But they do say this syndrome is likely not a disease mediated by a single immune specificity.
There you go.
Right. There could be others as well because they don't find limodin antibodies in all the patients and so forth. Right. So it's likely more complicated. But caution is necessary. I don't know if you remember, Dickson, on TWiP. A long time ago, we talked about in Scandinavia there was an outbreak of narcolepsy.
Oh yeah.
Supposedly associated with the flu vaccine.
That's right.
And they did some experiments which were published in Science showing it was an autoimmune reaction, and it turned out to be all wrong. It was retracted. So you got to be careful. Always.
Oops.
Yeah. Not because they were just fooled. They were just fooled.
Right.
Anyway, it's interesting. I think it's quite interesting.
Yes.
And if we should talk at all about the burden of this disease, as we mentioned, it's mainly 5 to 15, and rarely you'll see someone younger. Sometimes people will be even older. Older being up to like 30. But in some of these areas, it's really common. In some of the villages, I think they mentioned in this commentary here that 1 in every 6 children in certain households. Some cases, it's 50% of households have at least one child with epilepsy in these endemic areas.
Wow!
And it's epilepsy not easy to treat. The inexpensive drugs don't even work against this. So it's quite a significant problem in these areas.
Sure.
And as Vincent points out, maybe something that 1 dose a year of ivermectin could get rid of.
We need to go back to Merck and get them to donate more drug, because they did it years ago. They should do it some more.
I think they're still doing it.
You think? But only in the East, you think?
Only in West Africa.
West Africa,
yeah.
Yeah, they're still doing it. And actually the Carter Center, right, is a big,
that's right.
big, really very focused on trying to get rid of.
Why wouldn't they do it to all areas that need it, though?
Well, because when you look at the worm burden, it's huge in West Africa. I mean, absolutely huge. Blindness is a very common syndrome for this. In East Africa, it's not so common. I mean, it's when you have to compare those two zones.
What Daniel just said, if every household has a child with epilepsy, that's a burden.
It's a burden, but only recently do we think it's connected to a parasitic infection, though.
All right. Well, they should.
No, I agree.
Let's email this to Roy Vagelos. Oh, no, he's not there anymore. Sorry.
He's just up the river.
All right. Daniel, do you have any other comments before we move on?
Oh, I was driving around. I was listening to one of your old TWiPs back before I joined, TWiP 24, where you discuss river blindness, where you discuss onchocerciasis volvulus.
Yeah.
I was enjoying it, but there was one thing you mentioned I thought I should comment on. You, I think it must have come up on a Google search, the song "River Blindness" by the Jay Giles Band.
Yeah. Yep.
And you said, "Oh, that has nothing." No, actually, that is a song.
Oh, it is?
Yeah, and actually, to read the lyrics a little bit to our
sure.
And so it goes: human kindness, river blindness, black flies rise as the water flows.
Oh yeah, of course.
Human kindness, river blindness, angels cry as the fever grows.
Yeah, of course.
It talks. It's interesting. It actually talks about the disparities. Here are people living in wealth, while there are these people who are suffering from this disease throughout the world.
Why don't we post the lyrics on our
Jay Giles Band? Well, we'll have to put the lyrics in the title, right?
Sure.
What is that? River blindness what?
Human kindness, river blindness.
There you go.
Why would it be human kindness? Oh, giving away the drug.
Giving away the drug.
Yeah.
Excellent. All right.
Right.
Daniel, that's great. Who wrote it off, Dickson or me?
You did.
I was not aware of it.
Why would I say that without looking at the lyrics?
Jay who?
I apologize. Nobody.
I'm a big Jay Giles fan. Actually, I should. The first dance with my first girlfriend, right back in high school, was to a Jay Giles song. So,
my apologies to Jay Giles and all their fans, including Daniel, for saying that. All right, Daniel. Do you have a new case study for us that's not a Googleable?
This is ungoogleable. Yes. I was torn between two cases, but I will choose this one. Okay. This is the case of a young male in his 30s who presented to the emergency room with his male partner. This is a hospital in the New York area. And his chief complaint is over 1 month of rather significant diarrhea. He says that the diarrhea is watery and non-bloody. He's been experiencing abdominal cramping. He feels poorly. He has low energy. He does report fever, but he is not able to give us a clear fever pattern. He has had some episodes of vomiting. He reports that he has lost a noticeable amount of weight. He's not able to give us a specific number. And he just feels like he cannot keep up. He can't drink enough to stay hydrated. Okay. Past medical history. This patient was previously diagnosed with HIV infection. He's decided not to take medication, and his last CD4 T cell count was less than 50, and his viral load is elevated and uncontrolled. Past surgical history is negative. Allergies, no known adverse drug reactions. His family history is negative, non-contributory. Medications, as mentioned, none. He's not taking any antiretrovirals. Social history. Occupation, he had worked in an office but is no longer able to work. He's gotten weak and debilitated by the diarrhea. He lives with his male partner. He says he will occasionally drink alcohol. We have no reported travel outside of the New York area or overseas. He has no pets, no other significant exposures that he describes. Before I give you his exam and some lab results, any questions?
Do you find a lot of HIV-positive patients nowadays refusing therapy?
I'm actually finding less, and I think there's been changes in the sort of the thought and the groupthink regarding, and part of it I think is because the medicines have become less toxic. You know, let's say 5-10 years ago, I would ask a patient with HIV, and they would tell me, the most common cause of death for HIV patients is liver failure from the toxic drugs. I don't hear that nowadays. Now I hear people saying the most common reason you would die is failure to take the medication. So I think the medications, certainly deserved in the early drugs from all the side effects and everything else. They're poorly tolerated. They're very difficult. And now with these one pill once a day, well-tolerated combinations, we're getting, I think, much better acceptance among patients. But also, and this is really critical, doctors have come over to everyone should be treated as soon as the diagnosis is clear. And that did take a while before the studies really proved that was the case. And so there was a period of time when physicians were even waiting to start therapy. And it was that you should discuss therapy. And I think now across the board, it's you should recommend and encourage therapy for any HIV positive patient.
So what is your personal view as a physician with regards to this patient in terms of whether or not this represents a person who could spread HIV to a lot of other people before they die?
So actually,
so there's moral issues and ethical issues here, right?
Sure. Yes. Actually, it's a really difficult situation, and I'll say maybe this is my sort of liberal left leaning, but I think it's really essential that we as a society provide access to HIV medications, because otherwise a lot of patients have a feeling that they're disenfranchised.
Right.
Society is not taking care of me. I got this. I'm a victim here. If society is not going to work with me and provide this life-saving drug, then why should I, respect my social contract with this community and not just go ahead and spread it and give it to someone else the same way I got it.
So question, did you offer him the therapy at that point?
Well, we haven't really examined the guy. We're meeting him for the first time. But.
I got it. Okay, fine. Okay.
And actually, it's interesting. He was a long-term patient of a colleague of mine when he is admitted, or when I admit him to the hospital.
And his partner, was he involved in any of this discussion?
So his partner is also HIV positive and also not on therapy.
And did his partner have any of the same symptoms?
No, his partner does not.
Very good question.
All right. Did you do a physical exam?
Yes. So he is febrile. His temperature is 38.5 Celsius. So that's well over 100 for those in the Fahrenheit world. His heart rate is 115. His blood pressure is 95/65, and his respiratory rate is 18. He's a very thin male, and he's appearing uncomfortable. He's somewhat miserable. He's got oral thrush noted on his buccal mucosa. So when you look inside the mouth and you look on the sides of the cheeks, basically you can see the thrush there. He's got no subungual saliva. And people assess volume status many different ways, but when he lifts up his tongue, you don't see any saliva. Lungs are clear, heart's rapid. His abdomen is diffusely tender, and he's got increased bowel sounds. No clubbing, no cyanosis, no edema.
Increased bowel sounds, you said?
Increased bowel sounds.
All right.
And I'm going to give you labs, and then I'll let you ask any more questions. So he has a number of electrolyte abnormalities on his metabolic test, including an elevated creatinine, elevated BUN. He's got a decreased sodium, and he has an elevated white blood cell count with significant eosinophilia. So we have yes, it's not over 9,000. So we have an HIV positive gentleman with a CD4 count less than 50, uncontrolled viral load, not on antiretrovirals, with diarrhea and eosinophilia.
So he hasn't eaten anything unusual. He hasn't gone anywhere.
No, he's actually been relatively housebound over the last month as this diarrhea has gotten so severe.
So he has all of his food delivered?
No, he has a male partner who's doing the shopping and helping with the food preparation.
Right. And any unusual features of his apartment, like exotic plants or exotic animals or exotic anythings?
So he describes no pets and no houseplants.
No houseplants, okay. And no history of travel?
No history of travel other than, the immediate New York area.
Yeah, which could be anywhere in the world. Since people come here, we don't have to go there.
Of course. But it doesn't sound like he's not working anymore, so he's not having contact with people anymore.
That's right.
This sounds opportunistic to me, Dickson.
It certainly does to me too, Vincent.
All right. I'm okay. I'm good. Are you good, Dickson?
Yeah, sure. Till I see the slide with the organism, I'm good.
You must have some guesses, don't you?
I have lots of possibilities running around right now.
Yes, there are several, right?
Yep.
All right, we have... Yes, go ahead.
So as usual, I'll say, we want people to give us their guess, but give us a differential, and importantly, what is the next test? What should we order to try to cinch this diagnosis, and then, what should we recommend? So
okay,
indeed.
And this is not a Googleable case. I have not published this.
All right. Well, it's okay. A few people felt guilty about Googling, but that's totally fine.
But right? Is it in our 6th edition? That's what I want to know.
This, I will say, this is girls, everyone. This is in the Parasitic Diseases 6th edition.
Listen up.
You can find it there.
That's right.
If you can find it there, you can find it anywhere. All right, we have a few emails to read. Becca writes, Vince, Dick, and Daniel. Over the past few weeks, I've learned so much from your podcast. I got into parasitism while reading a fiction book called Peeps by Scott Westerfield. I loved learning about the parasites in the book so much that I bought Parasite Rex by Carl Zimmer, which I'm very glad to have heard you reference on the podcast.
Yep.
I think you should now download the 6th edition of Parasitic Diseases and read that.
There you go.
Currently, I'm a senior in high school, and come September, I'll be a freshman at Colby Sawyer College in New Hampshire studying environmental science. I know it seems a little early to be doing so, but I'm already thinking about grad school. I guess my question for you gentlemen is if there are any graduate schools that you would recommend for a degree in parasitology. Thanks, and keep doing what you're doing. Sincerely, Becca, an inspired youth.
Right.
Dr. Despommier.
Well, it depends on what kind of parasitology. If you want to go into medical or into, let's say, veterinary or wildlife, or, wildlife includes, lots of things like invertebrates and fish and things of this sort. Or if you want to be a doctor eventually, and you said graduate school. So graduate school, do research. So in my lack of experience in recent past, but in terms of what I presume is still true, places like UC Berkeley, University of Pennsylvania, Washington University in St. Louis, Tulane has a strong program, Harvard at the School of Public Health has a strong program in some aspects of parasitology or parasitism. Daniel, any thoughts about medical orientations here, ID programs?
Yeah. No, I think that's key, is getting a sense of where you're thinking of going with the parasitology. Yeah. If you're looking at clinical, like I want to see patients and diagnose them, you're looking at a medical school that has a strong international component.
That's right.
And if you're looking at basic science, where you do your undergraduate is going to be just getting good solid science and then deciding which area you're excited about, and then hopefully doing your PhD work with someone in that particular area.
Sure. There's a wonderful thing you could do, and that is you could go to an American Society for Parasitology meeting and see who's giving the papers and where they're from and what kind of research they're doing as a way of getting a tasting menu of what's out there before you actually have to choose a main course.
Or even ASTM&H, I would say, might be.
That's true. That's true.
Might be even better. I think that when you look at the numbers in the American Society of Parasitology, it's kind of small.
It is. I agree.
Yeah, and ASTM&H is really just a big, huge,
it is
robust group, and I think they're great meetings to go to anyway. So,
but I must tell you that Colby Sawyer Junior College, or college as it's now called, is where our Gordon conferences were held every other year.
Yep.
And that's, it was about parasitism, and then you could have, of course, met some other interesting people too.
Yeah, she has time, so she should explore. She should go to meetings. The meeting is a great place to find.
Exactly. And then another thing to do is, of course, go to PubMed. And if you're not even sure of what kind of parasites that you want to work on, pick the big ones like malaria, schistosomiasis, and lymphatic filariasis, and see where the people that are publishing in that area, see where they went to school. That's another thing to do.
All right. Dickson, next email, please.
Certainly. So I believe this person meant to say biomimic girl, but she's wrote Biomic girl.
It's a biome is something.
Okay, biome, absolutely right. So, okay, Biomic girl writes, canning it. That's regarding the possibility that we're going to give up this podcast.
Or specifically the clinical.
Yeah, she says, don't go anywhere. We're out there and we're listening even when we don't write in. Thanks for this podcast. That was pretty short.
Does that mean you want to take another one?
I would be happy to
go ahead.
That. So, David writes, Dear TWiP Wise Guys, and I hope he means that in the best sense of that word, based on the
by the way, this is an older case, which he did.
It is, that's correct. That's
the previous one
before this. Based on the eosinophilia, I went through the available worms that cause this, and Strongyloides stercoralis seems to be the most realistic option. The cough would be caused by the parasite traveling through the lungs. Diarrhea is a common symptom. The rash manifests where the unfortunate volunteer sat down in feces. The duration also fits with parasitic diseases, mentioning on page 245 a typical duration of 6 weeks. The larvae in the stool should confirm this diagnosis, and I expect the patient to have been cured by either albendazole or ivermectin. I actually did go through the differential diagnosis, but other options seem so unlikely and the source of infection so obvious that I looked no further, and I therefore hope my guess is right. Let me finish by expressing once more my admiration for your efforts. I know very well that it takes a long time to come up with even mediocre products. Thanks so much. And to offer a top-class podcast of over an hour, or in Vincent's case, several of them on a weekly basis is more than a hobby, it's a mission. Kind regards from windy Nicaragua, with just 31 degrees C. We could use a little of that here right now. David. Yeah.
I think that was the correct answer, Strongyloides.
It was the correct answer, and indeed it was.
Daniel.
Leela writes, Dear TWiP team, I've been enjoying the Peace Corps cases. My husband and I were in the Peace Corps in northern South Africa about 10 years ago. We were north and east of Thohoyadou. Luckily, the only parasitism we suffered, at least as far as we know, were bot flies. Our host family had several mango trees in the backyard next to the clothesline. I was very happy to return to my washer and dryer and stop ironing all my underwear. I attached a picture of us in our village. For the current case, I'm making a guess of strongyloidiasis. I think this is the same case, although I may be wrong since spell check seems to think this is not a word. These roundworms are transmitted through contaminated soil, thus the direct contact with soil, as well as the initial rash and eosinophilia fit with this diagnosis. Thanks for all of you for your hard work making TWiP such a fabulous podcast.
So they sent a lovely picture.
They did. It's a fabulous picture, in fact.
Oh, that's a great picture.
Love those.
So, Dickson, if you hang your clothes outside, then you got to be careful about botflies.
You do. Oh, they love it.
What would they do? They
lay the eggs on the soiled portions, and because you can't wash your clothes very well in these situations, and
then the eggs would do what?
The eggs will hatch as soon as you put them on, and then they will burrow through.
They hatch as soon as they put them on.
Oh yeah, it's triggered by warmth.
Oh. All right.
And then you end up with myiasis all over your, body, whatever, whether these are shorts, underwear, shirts.
You name it, and it's, I know, it's kind of bad. It's kind of bad.
Adam writes, Dear Vincent, Dickson, and Daniel, it is cold and wet in Belfast. My guess for this week's case study is strongyloidiasis, which should be remedied with ivermectin, but only if there are no relevant co-infections. I have been unable to get a decent diagnosis for the case studies recently, and I was particularly stumped by the relevance of kava to the previous case and the hypocrisy of an aid worker living with such expensive taste. I think I have this week's, though. I am now the proud owner of a TWiP color-changing mug, and although I'm doubtful of being the 14th emailer, I am happy to push someone else into that place.
Nice.
So Adam is a PhD student at the School of Biological Sciences at Queen's University, Belfast.
Nice.
Dickson.
Carla writes, Dear TWiP team, I love all of your podcasts. From not-so-sunny Ireland, we have a lot of emails from Ireland now, from Michaela, a longtime listener.
Cool. Daniel.
David writes, Dear hosts of my favorite podcasts, as long as there will be free books filled with biological scientific knowledge, I will keep on participating. So keep up the giving mood. Just heard the latest TWiP, and as it has been the 14th, I realize I am probably too late. Still, I should take a chance. We also try to find some time for a guest in the eosinophilia case today. Sincere greetings from Nicaragua, David.
That's who just sent in the guests.
Exactly.
All right, last one is from Mike, who writes, Greetings to the TWiP team. This letter is to take a chance on the free book, but more importantly, to answer Vincent's concern that no one was listening. I don't know who isn't, but I know that I am. I listen to the podcast after the fact on my iPod, and usually the cases and contests are old, so there's not much point to guess at the diagnosis when the following episode is already out. Regardless, keep up the good work. I am listening to TWiP and TWiV, though not in real time. So this is a letter from the past to the past, I guess. That's great. Best regards to you all. Mike Martin, general pediatrician, Rochester, New York. Love to hear who's listening.
Yeah.
Isn't it great, Dickson?
It's fantastic.
Now, are you finally convinced of the power of podcasts?
Vincent, I was never unconvinced.
Well, I think in the beginning you were skeptical.
No, before I met you, I was unconvinced. Get it? Unconvinced.
Wow.
It's a stretch. I know. Sorry about that.
This is TWiP. You can find it at iTunes at microbe.tv/TWiP. You can also find it on your iPhone or actually any smartphone, any tablet device that has either the iOS or the Android operating system. There will be lots of apps that can play podcasts, and inside of those you can subscribe automatically for free, so you get all the episodes. Please subscribe. Even though, 1 week you might not listen, just subscribe. One person told me once, I download them manually because I want to control what goes onto my phone. Oh my gosh. Come on, just subscribe. And also consider supporting us financially. You don't all have to do that, but if you feel the desire to help us out in ways, because we have bills and we'd like to travel and such, you can go to microbe.tv/contribute. There are a number of ways, including Patreon, where you could give us $1 a month, or PayPal, give us a bolus. If you gave us $20, which a few people have done recently, that's like 2 years and change of support. Or you can. There are other ways as well. We'd welcome your support. We will be eternally grateful for your support.
No question.
We love getting your questions and guesses to the case studies. We understand if you don't listen right away and the next episode is out. That's fine. But you can send them to TWiP at microbe.tv. Daniel Griffin is here at Columbia University Medical Center. He's also at parasiteswithoutborders.com. Thank you, Daniel.
Oh, thank you. A pleasure as always.
He's wearing a bow tie today. Now,
yes.
Listeners can't see him, but I will describe a blue bow tie with virus particles on it, drawings of virus particles, which happen to be polioviruses. And
something near and dear to your heart.
I guessed that before, and And Dickson said, "You're just a one-trick pony."
I never said it like that.
Insinuating that I had no other knowledge. Which is deeply offensive, Dr. Despommier. I don't know all about parasites for sure, but I know what questions to ask.
You do. Yes, you do. Yes, you
Daniel,
do.
Thank you so much.
Thank you.
And I like that bow tie.
Oh, he's got a great collection, actually.
I love the glow there from his
He's got
monitor.
microbial bow ties that go beyond.
I know, he's got a lot. We were the beneficiaries of some ties.
Yes.
And cufflinks at the very beginning.
That's right.
Dickson Despommier is at trichinella.org and thelivingriver.org. It was also at parasiteswithoutborders.com, working on his lectures. Thank you, Dickson.
You're welcome, Vincent.
So Dickson is going to record, Dickson and Daniel are recording a series of lectures in parasitology, which will be posted on Parasites Without Borders.
And we couldn't do it without you.
And that should be quite a resource.
We're going to try hard.
It should be very
to make
interesting.
Interesting, fun, and informative.
I'm Vincent Racaniello. You can find me at virology.ws. The music you hear on TWiP is composed and performed by Ronald Jenkins. You can find his work at ronaldjenkins.com. I'd like to thank the sponsor of this episode, Blue Apron. You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon. Another TWiP
is
parasitic.